Good day, Dr. Brennan and classmates. So this is Cheryl Sator, and I'm currently completing my clinical residency at California Primary Healthcare. It is a privately owned primary healthcare clinic at Glendale, California, headed by Dr. Rodolfo Portasio and supported by her team of nurse practitioners. So today, I would like to present an in-depth presentation of a case involving a 65-year-old Filipino female who recently migrated from the Philippines and presents to the clinic with multiple comorbidities, including history of hyperthyroidism, now presenting with worsening thyroid eye disease. This case was meaningful to me as it challenged my critical thinking, collaborative, and cultural competency skills with hopes of providing holistic, competent, and compassionate care. It enhanced my abilities to provide evidence-based approach, holistic care, and treatment plan. So patient's initial is MM. Date of birth is 10/18/1959. She's a 65-year-old Asian Filipino female accompanied by her daughter. She's a good historian. Her chief complaint, and I quote, "My eyes are bulging and irritated. I can't sleep. I'm always tired and I feel nervous all of the time." Her history of present illness, she has multiple complaints that have progressively worsened over the past 3 months. She reports bilateral eye protrusion, insomnia, unintentional weight loss of 12 pounds over the past 3 months. She's feeling warm most of the time and occasional palpitations. She used over-the-counter eye drops with minimal relief. She denies fever, chest pain, or shortness of breath. Concurrently, MM expresses difficulty in adapting to her new environment, citing challenges with the healthcare system, language barriers, and adjusting to new diet. She mentions feeling isolated and missing her support system back in the Philippines. So her previous illnesses, she had hyperthyroidism, which was diagnosed 5 years ago. She had osteopenia, hypertension, tuberculosis, which was treated 30 years ago in the Philippines. She had no previous surgeries or hospitalizations. She is up to date with all her vaccines, including COVID-19 and the booster, her Tdap, her shingles, her pneumococcal, and influenza with a recent dose in September of this year. She takes the following medications: methimazole 10 milligrams daily, propranolol 20 milligrams twice daily, amlodipine 5 milligrams daily, calcium 600 milligrams plus vitamin D 800 international units daily. She uses artificial tears as needed. She has no known drug allergies or medications or food or seasonal. She denies smoking, drinking. She reports increased appetite but maintains a balanced diet with no specific restrictions. She walks 30 minutes 3 times a week but is limited now due to recent eye discomfort and fatigue. She is a retired teacher, currently helps with childcare for her grandchildren. She lives with her daughter and family in a small apartment. She has limited social support system, mostly relies on daughter and video calls with friends in the Philippines. Her insurance is through her daughter's employment. Family history is significant with the father who had hypertension disease at age 75. Her mother had hypothyroidism disease at age 76. She had a sister that had Graves' disease. Her review system includes, she reports fatigue, weight loss, and heat intolerance, occasional palpitations, but denies chest pains. Her HENT, she is positive for eye protrusion, foreign body sensation, tearing, and occasional diplopia. She reports nervousness and anxiety. She reports fine tremors by lateral hands, but all of her other systems are unremarkable. On physical exam, patient is in alert and oriented times for female. She appears anxious but not in acute distress. Vital signs are within normal limits. Her cardiovascular and respiratory assessment are unremarkable. Her HENT exam reveals bilateral exophthalmos, more pronounced on the right eye, eyelid retraction present bilaterally, conjunctival injection and chemosis noted, extraocular movements intact but with discomfort at extremes of gaze. Visual acuity is 20/30 on both eyes without correction. Thyroid assessment revealed a diffuse enlargement with no distinct nodules. She was noted with fine tremors on outstretched hands. All other exams were unremarkable. Blood work collected and reported 2 weeks ago prior to this visit revealed decreased TSH and elevated T3 and T4. Her CBC and metabolic panel were within normal limits. These findings, together with the physical exams, have directed me to the following differential diagnosis. The first one is poorly controlled Graves' disease with ophthalmopathy, which is most likely given patients' history, thyroid function tests, and characteristics eye symptoms. Toxic multinodular goiter with secondary ophthalmopathy was also considered. It is possible but less likely given diffuse thyroid enlargement. Thyroiditis with ophthalmopathy was also considered but less likely due to chronicity of symptoms. Another differential is adjustment disorder with anxiety but likely comorbid related to recent migration and life changes. Major depressive disorder was also considered in the context of recent widowhood and migration stress. And lastly, vitamin D deficiency, common in immigrant populations, may contribute to fatigue and osteopenia. So, based on these assessments, clinical presentation, and risk factors, my primary diagnosis for MM is poorly controlled Graves' disease. This is an autoimmune disorder in which the thyroid gland produces too much thyroid hormone. When Graves' disease is untreated and is not well controlled, some people may experience complications like arrhythmia, heart failure, and stroke. Another diagnosis is secondary diagnosis is Graves' ophthalmopathy. This is an autoimmune inflammatory of the disorder of the orbit and periorbital tissues of the eyes. And the final diagnosis, another final diagnosis is adjustment disorder with anxiety. This is also importantly considered, which is common in patients with chronic autoimmune conditions. They manifest as excessive worry about disease progression, societal anxiety related to appearance changes, and difficulty coping with treatment regimens. So for our treatment plan, we start with the diagnostics, which includes thyroid ultrasound to assess for nodules and overall gland size. We can order orbital CT scan to assess extraocular muscle involvement and degree of proptosis. We can also do a 24-hour Holter monitor to evaluate for possible atrial fibrillation. We can also check the visual field testing to rule out optic nerve compression. We have to test the vitamin D level as well as the hemoglobin A1C to screen for A1C. For diabetes. For our therapeutic treatment, we have to include the following. We have to increase the methimazole to 15 milligram daily. We have to continue the propranolol, amlodipine, the calcium, and the vitamin D. We have to increase it to 2,000 international unit daily. So for patients with mild active TED, particularly in regions of selenium insufficiency, a single course of selenium selenite, 100 unit gram twice daily for 6 months may be considered. We can also increase the artificial tears to every 2 hours while awake and also prescribe lubricating ointment for nighttime use. We can also initiate melatonin 3 milligrams at bedtime for insomnia. For education, we have to counsel the patient on the importance of medication adherence, discuss potential need for radioactive iodine therapy or thyroidectomy if medical management fails. We also have to advise patient on sleep hygiene techniques, educate on proper application of artificial tears and ointment, discuss importance of vitamin D supplementation and sun exposure. And of course, we have to reiterate the importance of healthy lifestyle modifications, including diet and exercise. So follow-up will be in 2 weeks to reassess symptoms and review lab results. A referral to an endocrinologist for management of difficult to control hyperthyroidism is urgent, as well as to an ophthalmologist and a registered dietitian. We also have to refer MM to community resources that provides programs for senior care to support healthy living, socialization that will improve her language difficulty. MM has good comprehension of English, but she needs more time to fully understand the communication process. Recognizing the needs of patients with TED extends beyond national boundaries, and to enhance international knowledge and practice exchange, the American Association of Thyroid Association and the European Thyroid Association collaborated to create this consensus statement. This forum was chosen to be a consensus statement rather than a clinical practice guideline in order to offer a concise and timely evaluation of a therapeutic arena that is swiftly evolving. So the evidence-based approach plan includes early diagnosis and simple measures. An endocrinologist referral pathway is also important for thyroid eye disease, especially for specialty care. The assessment of patients with TED includes activities, severity, trend across time, and impact of daily living. The physical and psychosocial impact of TED must also be addressed. With much consideration to this patient's complex physical symptoms and sociocultural circumstances, I've utilized Jean Watson's caring processes, particularly the process of creating a healing environment to promoting a sense of trust and rapport in order to provide holistic care to promote better healthcare outcome for this patient. This involves practicing loving kindness, authenticity, and trusting relationships. Examples include building rapport, ensuring she felt understood and supported throughout her care. I collaborated with patient to explore options for her ongoing care, connected her to local senior care resources for holistic services, including socialization, engaging the family members, and creating culturally appropriate health education materials to break the barrier of miscommunication. The approach fosters a supportive, empowering, and respectful environment, respecting cultural beliefs and patient-centered and holistic care. In conclusion, this case underscores the importance of a thorough and evidence-based approach to patient care, especially in the cases involving multiple risk factors with coexisting psychosocial problem. It is crucial to integrate evidence-based approach to deliver effective and compassionate care. I hope this case serves as a reminder that the critical role of advanced practice nurses in managing and improving outcomes. This concludes my presentation. Thank you for your time.